Niba Mishra, your time starts now.
Good afternoon, everyone. It's an honor and privilege to be presenting in this particular session. Today, I am going to present my title, research title, Advanced Glycation End Products are the Biomolecular Biomarkers of Proliferative Diabetic Retinopathy. I have no financial disclosures too. Diabetic retinopathy, as we all know, is a major neurovascular complication of diabetes mellitus. We are living in a world where diabetes mellitus is growing at the rate of epidemic, as well as what we are seeing is the diabetic retinopathy, which is the vision threatening or the functional group of people. It is also causing a lot of problem. So we are leaving no stone unturned to find out our ways to get through with this disease. So starting with the main thing, that is the pathogenesis. Hyperglycemia is the main triggering thing which happens in diabetic retinopathy. What is being most studied nowadays is the non-enzymatic glycomatic reaction which acts on the proteins, lipids, and nucleic acids, which forms the basic skeletal framework of all our body structures, and that results in the formation of advanced glycation end products. The molecule which I have studied and is the most common is the N-carboxymethyl lysine. And here comes the concept of metabolic memory. What is metabolic memory? That once the proteins, lipids, and nucleic acids are irreversibly damaged with the formation of ages, even on reversal of hyperglycemia, it's not going to go back, and this damage is permanent. So my objective is to evaluate the role of ages as the biomolecular biomarker for PDR in type 2 diabetes, because that is the main vision-threatening issue. My inclusion criteria consisted of, it's a cross-sectional study at the tertiary care center, consecutive ophthalmologically naive type 2 diabetes mellitus patients ranging from age 40 to 65. After proper fundus examination, on the basis of ETDRS, we divided them into no diabetic retinopathy, NPDR, non-proliferative, and proliferative diabetic retinopathy, each group having 20, and an age and sex match controls were taken. The exclusion criteria was that no retinal vascular pathology should be pre-existent. There should be no prior treatment, treatment naive patients, and the conditions where NCML or ages levels are high, like in Alzheimer's disease or pulmonary fibrosis, should be excluded. We did a detailed data collection of demographic detail, best corrected visual acuity, and fundus examination was done. The blood investigation was done. The glycemic status was assessed by fasting postprandial and HbA1c, and assay of NCML was done by quantitative sandwich enzyme immunoassay technique. The main statistical analysis where our research was based was the receiver operating characteristic curve analysis. Our study was, all the 4 groups were age and sex matched. What we can notice significantly here is that the NPDR and PDR groups have a duration which is comparable. There is no significant difference. Definitely the main visual acuity is decreasing as we are going towards a more severe disease. And as per ANOVA, all the 4 groups are showing that there is a p-value more than 0.001 increase, and there is a significant decrease of NCML. But what is noticeable is fasting PP, postprandial, and HbA1c and NPDR and PDR is comparable. So here comes the role of NCML. We have plotted a ROC curve adjusted for age, sex, and HbA1c, and what we found that the area under curve came out to be 0.842, and as we know that this is a good, because 0.9 to 0.8 values are considered good for ROC curve analysis. So also we can see that the blue line is PDR line, and it is more towards, away from the 50-degree axis and more towards the y-axis, that is for sensitivity. And thus, this is a very good diagnostic tool for dichotometers finding that yes or no, the disease is present or not. So the ages-range axis lead to continued cellular dysfunction. Ages cause retinal parasite apoptosis, stimulate VGFs. Ages trigger oxidative stress. Ages thus are the new therapeutic targets. We can see that everything is being affected by them. So the glycemic control, HbA1c, which is being used, why not use it now? There are genetic variants. Sometimes it's reversed also, but we see that the patients are saying, I'm still having the disease. So ages are the major biomolecular biomarker, pathophysiology of the evolution of diabetic retinopathy, and are novel therapeutic targets along with anti-hypertensive, anti-glycemics, and they are being studied now. Ages are the new age tools of translational medicine, and we should put a focus on that. Thank you.
Thank you, Dr. Niba. Is there any questions from the... No? Okay. We are running a little short of time. Get your spell checks done when you do. So discussion in 2 slides was without an S. Yeah?
Okay.
Okay.
Thank you.
Thank you.
You want to do it first? Yeah, sure.
Please don't move from the hall after your presentation. be here to go through all the presentations.
Go ahead.
Now I call upon the next.
No, they've got to change in order. I'm sorry. Somebody has to go somewhere.
Serial number?
19, she is Dr. Marushka.
Yes.
Yeah, right. It's squint, third nerve palsy, medial rectus resection versus fixation to medial palpebral ligament. Can we have that presentation on, please? The
There is a
presentation
change in
on.
the order.
Not this presentation.
Change in the order, yes, sir.
Present in the
19.
paper is Dr. Janani Rajan, Maruksha
Yes, sir.
Obear.
Marushka.
Presentation on.
Okay. Good afternoon, all. Today I'm going to present our work on third nerve palsy, medial rectus resection versus fixation to the medial palpebral ligament. So we know that surgical management of oculomotor nerve palsy is very challenging. It requires meticulous surgical planning. There is no clear consensus about treatment, and it usually results in long-term surgical undercorrection. So our aim was to compare the results of lateral rectus deactivation combined with medial rectus resection and combined lateral rectus deactivation with medial rectus fixation to the medial palpebral ligament performed in the same operative session for oculomotor nerve palsy in terms of successful alignment and ocular morbidity. It was a retrospective analytical study between Jan 2006 to June 2020 at Arvind Eye Hospital, Madurai. We had a total of 35 patients. So all our patients with complete oculomotor nerve palsy with large angle exotropia, more than 50 prism diopters, underwent lateral rectus deactivation of the affected eye. In group 1, we combined this with medial rectus resection, and in group 2, we combined it with MR fixation to the MPL. Our inclusion criteria were all patients with oculomotor nerve palsy with a follow-up of at least 6 months after diagnosis. We excluded patients who underwent previous strabismus surgery or those with neurological abnormalities. So all our patients underwent a detailed ophthal evaluation, including oculomotility testing and measurement of the deviation. The FDT, FGT in clinic was done for all adult patients. Intraoperative FDT was done for all patients. All our patients were operated under general anesthesia by a single surgeon. We measured the ocular deviation on postoperative day 1 and 6 months. Our success criteria was a horizontal deviation less than or equal to 20 prism diopters in primary position at 6 months post-op. So for lateral rectus deactivation, after isolating the LR, it was hooked with secured with a 5-0 polyester suture, disinserted from the globe. We then made a hockey stick incision over the lateral orbital rim, exposed the periosteum and posterior tenons, retrieved the LR and secured it to the periosteum and closed the posterior tenons. In the first group, this was combined with 10 mm of MR resection. In the second group, we fixed the MR to the MPL. So after exposing the MR and the MPL insertion, we passed 5-0 non-absorbable sutures through the insertion of the MPL, including the periosteum, and then tied these two knots together. We then passed an empty semicircular needle through the skin, through the conjunctiva, above the MR insertion. We threaded this needle through the semicircular needle so that we brought it out above and below the insertion of the MR. We then secured this to the MR insertion superiorly and inferiorly and fixed the eye in 10 degrees of ISO. So we had 20 patients in our resection group, 15 in fixation group with an age range of 3 to 65 years. We see that on post-op day 1, both groups performed excellently, correcting the exotropia. But at 6 months post-operative, only 65% of patients in group 1, as compared to 93% of patients in group 2, could maintain this. If we see, the results are not statistically significant. What is statistically significant is the residual exotropia at 6 months post-op between the two groups, with group 2 performing much better than group 1. So we did not observe any significant postoperative complications in the resection group, but the fixation group had persistent medial conjunctival congestion in one patient with a suture granuloma in the second patient. So this is a preoperative and 6 months postoperative picture of LR deactivation with MR resection. And this is LR deactivation with MR fixation to the MPL, 6 months post-op. So in the first group, we felt it was a technically simple procedure, no important structures present laterally. The post-exotropic drift could be due to slackening of the MR, and there was less severe limitation of ocular motility. In the second group, being with a fixation to the MPL, it was slightly difficult with extensive tissue dissection, poor cosmesis. You can have injury to lacrimal sac and angular vessels, persistent epiphora, and severe limitation of ocular motility post-op. Our limitations are that RCTs would be better to assess the procedure. We did not see them beyond 6 months. The number of patients in each group are different, and due to our relatively small sample size, our results were not statistically significant. So in conclusion, we would like to say that both techniques give a good reconstructive correction of large angle exotropia, but LR deactivation with MPL fixation, though requiring more time, prevents a long-term post-operative exotropic drift. Thank you.
Thank you, ma'am.
Thank you.
I call upon the next Dr. Shell Vasavda for next presentation. Her topic is from cataract.
Yeah. So sharing visual outcomes following implantation of an extended depth of focus IOL in patients with macular degeneration. This study was part funded by research grant support from Alcon Laboratories, USA. So the purpose was to evaluate the visual outcomes following implantation of a non-diffractive extended vision IOL in patients with pre-existing early dry age-related macular degeneration. It was a prospective interventional case series performed at Raghudeep Eye Hospital at Ahmedabad and Jaipur, and all adults above 40 years of age having non-traumatic cataracts were included. All eyes underwent phacoemulsification with in-the-bag implantation of a non-diffractive wavefront shaping extended vision IOL. Patients included were with uncomplicated age-related cataracts ranging from grade 1 to 4 on the LOCS grading system, and pre-existing stable age-related early dry macular degeneration, which was defined on the AREDS2 criteria, that is multiple small drusen's less than 63 microns or few intermediate drusen's between 63 to 125 microns, or pigmentary changes at the macula. So the diagnosis was done both on fundus photography as well as on posterior segment OCT on the macular scan. All cases with either wet macular degeneration or not fitting into the AREDS2 criteria of early ARMD or any other ocular comorbidities were excluded from the study. The primary outcome measure was monoocular corrected distance visual acuity at 4 meters on the ETDRS chart at 3 months post-operatively, and the secondary outcome measures were monoocular unaided distance visual acuity at 4 meters on the ETDRS chart, monoocular uncorrected and distance corrected intermediate visual acuity at 66 centimeters, and monoocular uncorrected and distance corrected near visual acuity at 40 centimeters. All of these were evaluated at 3 months post-operatively. The age range was 68.5 plus or minus 8 years. There were equal number of male and female patients and almost an equal number of right and left eye. The average axial length was 23.37 plus or minus 1.1, which means no gross myopic or grossly hyperopic eyes were included. And the average nuclear sclerosis was grade 2. 63% of eyes also underwent the toric version of the extended depth of focus IOLs, as all of them were evaluated using the Barrett's Universal 2 toric calculator. Coming to the results, the distance visual acuity, unaided distance visual acuity was 0.12 plus or minus 0.7 at 3 months post-operatively, whereas the corrected was 0.1 plus or minus 0.1 at 3 months. So 0.12 is roughly equivalent to about 6969 parts on Snell's visual acuity. So the mean corrected distance visual acuity equivalent Snellen's was about 6 to 7.5. The unaided intermediate visual acuity was 0.25 and the unaided near visual acuity was 0.23, and both of them corrected improved to 0.1. The near add, average near add needed for at 66 centimeters was 0.86 plus or minus 0.18 diopters, and the near add needed for 40 centimeters was 1.3 plus or minus 0.18. The most important part of the study, the contrast sensitivity in mesopic conditions with and without glare at all different cycle speeds did not show any significant worsening with glare or without glare and were comparable. There are early reports of literature showing good outcomes of these extended depth of focus IOLs in subtle macular pathologies. The strength of our study being that we strictly followed the AREDS criteria based on fundus as well as posterior segment OCT evaluation. And therefore, we conclude that this IOL had a very good distance visual acuity along with good intermediate and near visual acuity, but most importantly, without compromising contrast sensitivity. Thank you so much.
Thank you, Dr. Shail. Now we go on to the next speaker, Dr. Ankita, for her presentation from Community Social Ophthalmology.
Thank you, sir.
On that segment.
Good afternoon, everyone. I'm Dr. Ankita Thali, and I'm here to present Teleconsultation, Ophthalmology Reaching Every Nook and Corner. So teleconsultation refers to the use of technology to deliver healthcare remotely. Ophthalmology is a technologically forward branch. The first project in teleophthalmology was published in 1975, and of course it played a major role during the COVID-19 pandemic. The aim of our study was to analyze the impact of teleconsultation in India's rural community. Subjects and methods. So first we talk about the teleconsultation units, which are set up in rural communities, which we refer to as vision centers, each one catering to a population of about 20,000 to 50,000. Each vision center is equipped with modalities for slit lamp and fundus photos, shiots, tonometers, trial sets, retinoscopes, and optometrists, and a good network for communication. We also have sphygmomanometers, glucometers, electronic medical records, and an optical shop. So the optometrist basically takes the history, does the examination, takes the slit lamp photos, fundus photos, and sends them to the doctor at the base hospital. The base hospital setup consists of an exclusive room which is equipped with 2 computers and a good network connectivity. At a time, there are 2 ophthalmologists and 2 staff nurses. The teleconsultation is then carried out using Skype and Remedio app. So basically, the video consultation is done with the help of Skype, and the data, that is the images, is viewed with the help of the Remedio app. So a systematic retrospective analysis was done over a period of 18 months from April 2022 to September 2023 on data which was obtained from 41 such vision centers of 10 of our hospitals spread across 9 states in the country. As you can see, this is the image of all of our vision centers in the country except for Coimbatore, because Coimbatore alone has 17 vision centers. So the data included the number of patients that were examined, treated, and referred to the base hospital, the demographic profile of these patients, what conditions were being treated, and the number of cataract surgeries that were performed. The results that we found were total patients that were examined were 1,91,194 with an average of about 10,366 per month. Maximum number of patients was seen at Coimbatore, about 44.78%, but then again this is due to the maximum number of vision centers. The demographic profile of these patients showed that most of our patients were females and more than 60 years of age. And the visual acuity of most of the patients was between 6/60 and 3/60, that is they had severe visual impairment. Presenting symptoms, the most common one was diminution of vision, and the most common diagnosis that we had were lens-related pathologies. But then again, like any other patient, patient would come with more than one presenting complaint and more than one diagnosis. Discussion, Born et al. In 2020 found that with a population of 1,380 million, India has 270 million people living with vision loss, and out of which 9.2 million were blind. In developed countries, the average ophthalmologist to population ratio is about 39 per million, whereas in India it is only 15 per million. Within the country itself, urban areas have got one ophthalmologist for every 10,000 population, whereas in rural areas there is only one for 250,000 people. Therefore, teleconsultation can help to bridge this gap. Also, we found that females were more than males. We have previous studies similar to Sabharwal et al. Also. This could be due to inability to travel the long distances to the hospital, and also due to social responsibilities of the females. Also, more patients were more than 60 years of age and those with severe visual impairment. Again, it could be due to increase in the lifespan of the population and also difficulty in traveling to far off distances by such ailing patients. We found that 37,713 patients had cataract and were advised cataract surgery. Out of these, 62% patients were below poverty line and underwent cataract surgery completely free of cost. 65,425 patients were given medication with the help of teleconsultation, and on follow-up were found to have resolution of symptoms. And almost 31,000 patients had a refractive error and were given spectacles. With all of this, it is very clear to us that teleconsultation can indeed help to reduce the burden on the healthcare system. Posterior segment pathologies, of course, it helps in early diagnosis, referral, and treatment. There have been studies also proving this, that teleconsultation can help in early diagnosis. Similarly, even for glaucoma, which is an irreversible cause of blindness, there have been studies that have been showing teleconsultation can help in early diagnosis in glaucoma and referral to the hospital. But then again, we cannot overlook the limitations, the most important one being cost effectiveness. Obviously, to initially set up the vision center takes a lot of money, but we need to not forget the long-term benefit that we get from it. Poor network connectivity in rural areas is another limiting factor. And of course, there are certain conditions which cannot be diagnosed by teleconsultation alone. But then again, we have to see the benefits. It is beneficial to both. ophthalmologists and patients, and aids in case-based reference. Most studies have shown high satisfaction patients among ophthalmologists as well as patients. It improves public awareness, improves health-seeking behavior, and the post-operative care and follow-up can also be done. To conclude, teleophthalmology serves as a good eye care delivery channel. It provides preventative, curative, and promotive eye care services in a sustainable way. No doubt, it was a major source of healthcare delivery during the COVID-19 pandemic. However, even now, during the post-COVID-19 pandemic era, it is here to stay. Thank you.
Thank you, Dr. Ankita.
Thank you, sir.
You will all agree that teleophthalmology was of a great help to us during the COVID and immediate post-COVID period. Thank you.
Thank you, sir.
Now we go to the next speaker, Himadri Chaudhary from Comprehensive Ophthalmology segment.
A very good afternoon to one and all. I'll be talking on smoke in the water, liquid tobacco use in Northeast India. I have no financial disclosures. Of all the many colorful and wonderful tribes of Northeast India are the tribes of Kuki, Mizo, and Mar. They mostly hail from in and around Mizoram and Manipur and Dima Hasao district of Assam. I hail from Kachar, so I get a lot of patients from these areas. So coming to the background, the purpose was to report toxic nutritional optic neuropathy in young patients belonging to indigenous tribal communities of Northeast India. All patients presented with diminution of vision in both eyes. A detailed medical and dietary history was taken, and all patients gave a history of tobacco use in liquid form, while 2 patients gave history of occasional smoking as well. So what is this liquid tobacco? I had seen a couple of my patients taking sips from a bottle in their hand containing this brown colored liquid. I was really intrigued. So on a little investigation, I found out that the local name is Tuibur or Hidakfu. It's a form of tobacco water mainly popular in northeast states of India, and it is part of social customs. It has got widespread cultural and social acceptance among these communities. It's almost as common as tea or coffee. And there is this misconception that tobacco causes purification, water causes purification of the tobacco, and it's safe to use. So I decided to investigate further and went to a local Mar village to find out what is going on. So the tobacco is first dried, then it is put in these earthen pots and it is put on fire. Then using a manual hand pump, the smoke is pumped into the water. And it is continued. The process is continued till it becomes super saturated. Then a simple liquid, simple filtration is done, and this is the finished product. So the people were extremely generous to me. They also offered me a drink, but I had to decline it respectfully. So hydrocyanic acid and free radicals in tobacco deteriorate the mitochondrial respiratory chain of DNA. It causes modifications of mitochondrial morphology. This leads to demyelination. So we did clinical evaluation along with visual fields and OCT. All patients were started on oral vitamin B complex supplementation along with methylcobalamin for a period of 3 months. And we advised them to discontinue this liquid tobacco or tuibur. This is a typical patient, normal fundus, normal OCT, only a central scotoma on visual fields. But a month after treatment, there was a dramatic improvement and visual acuity improved to 6/9. These are a couple of other patients. So vitamin B complex supplementation has been useful in treating tobacco amblyopia, and the protective effect is believed to be due to conversion of free cyanide to cyanocobalamin. So all patients who had presented with diminution of vision had significant visual improvement improvement in visual acuity and visual field indices after treatment. Although the use of tuibur has been published before, but to the best of our knowledge from our extensive search of PubMed, Google Scholar, Science Direct, this is the first study linking the use of liquid tobacco or tuibur to toxic nutritional optic neuropathy. In summary, nutritional toxic optic neuropathy may be caused by a multitude of agents. The mainstay of treatment involves replacing the deficient nutrients and eliminating the offending agents. It is also important to consider contributory social, cultural, and dietary practices. So rock music is extremely popular in Northeast India, and I will finish my presentation with a rendition.
Thank Thank you, Dr.
So we
Chaudhary.
can have 1 or 2 questions. We have time.
We go on to the next speaker.
So we can have 1 or 2 questions, sir. We can take questions
If
from
you have,
no, sir, from the judges.
Have you done a VP in any of this patient? Because these are all
No, ma'am.
toxic.
We don't have access to VP. We haven't done.
Because that is one of the main criteria to know that optic nerve is involved or not.
Yes, yes.
How does it add to the knowledge? The only thing is that it's liquid. Tobacco amblyopia is
Well, we were not aware of this entity because we initially asked whether they smoke or not, and they just say that no, we don't smoke. But after we found out in our patient's hand, that's when we realized that we are dealing with something else.
Yeah. Sharon?
Good afternoon, everyone. So as we know, corneal blindness is one of the leading causes of blindness in the world, but the great thing is that it is a reversible or treatable cause of blindness. For many of these conditions, such as Fuchs endothelial dystrophy or corneal decompensation, the treatment is an endothelial keratoplasty or a full-thickness keratoplasty. However, global shortage of corneal tissue availability and, of course, problems related to graft-like rejection and failure then go back into a vicious cycle of leading us to shortage of tissue. So what is our way to bypass this? Groups around the world have been trying to research and find ways of generating and transplanting corneal endothelial cells. And one of the greatest works that we have is the landmark work by Professor Kinoshita et al., who have tried to generate endothelial cells from corneal endothelial tissue. The challenges there, of course, is the limited expansion of cells. If you remember, endothelial cells do not generate on their own and do stop, have a cell arrest at the G1 phase. In addition, there is a lot of endothelial mesenchymal transition, which means these cells tend to go into fibrosis much more when we are trying to expand them. And of course, the issues with transfer and viability. So because of that, we were trying to find an alternate source because already the corneal tissue is less and we are trying to expand from there. So is there an easier way or a better way from something that we have a lot of? So we are trying to generate corneal cells from our peripheral blood, a normal blood sample which we can use to generate cells. And how did we do this? And this was the plan of our work, to generate induced corneal endothelial cells. That's not enough. Those generated cells now we need to integrate into a substrate because that's where it's going to be in the cornea. They have to maintain their morphology and function. What are the various approaches we can do this? Go into animal experiments and then on to clinical trials. So this was our work till now, where we've used peripheral blood cells, which were reprogrammed using a Sendai virus into pluripotent stem cells, and then finally into corneal endothelial cells. Now, it's not enough for us to believe these are endothelial cells. They have to be characterized by various markers, which I will just show in the subsequent slides. So if you remember the classic endothelial morphology of hexagonality, in the third slide, you can see that the cells do appear like our endothelial cells, which have to have an edge-to-edge apposition. But appearance is not enough. They have to have the classical markers. Zonal occludence 1 is a paracellular barrier, which we know regulates the permeability, which is so important for corneal endothelial cells, and these cells of ours did show these markers. In addition, the classic sodium-potassium ATPase pump, which is so essential for the detergence of the cornea, was also shown on our cell markers, and also the non-muscle myosin, which is very, very important for migration and addition. So stepping forward to our next step is the aim of the study, where we wanted to integrate these cells now into the cadaveric corneal tissue. So we looked at 10 cadaveric eyeballs, where we took these cadaveric eyes and did an atraumatic denudation of the endothelium. It has to be atraumatic because we are going to use the DM, which is left behind, as a substrate. Following this, we injected the cells, which were cultured into in that position, and then we cut the corneal button and flat mounted it to check again the same markers which we've already shown to be shown in the cells. We want to check them again in the integration. We found that before endothelial cell removal on the specular microscopy, you can see the beautiful endothelial cells there. After the endothelial cell removal, there is no cellular morphology. And after injection of the induced corneal endothelial cells, you can see some appearance of the adhered corneal endothelial cells. Similarly, we did show that even after integration by IHC and IF, the same markers, that is the zonular occludence, was found on the integrated cells on the cadaveric cornea. And they also had the functionality of a corneal endothelium, which was the sodium-potassium ATPase and the non-myocyl markers. So we have successfully then managed to have endothelial cells which are now integrated onto the cornea. So what next? We have now moved into the animal experiments, but we are looking at finding new ways of how to inject it, and one of them being either to have a collagen scaffold or to have something like a DMX scroll on which we've integrated the cells and push it in, because as surgeons, that is something which is convenient and close to us. So we are finding alternate sources of the endothelial cells, and that's why when we have so much of blood, we're using that as a source for us. We are now into the animal experiments, and where we are is we're using the New Zealand white rabbit, which is a very good source of an animal subject because the size of the cornea is comparable and easy for us to handle. And once we are injecting the cells, we will repeat the exact same steps of the standardized protocol that we have made to find out if we can be successful in that next step. Thank you for your patient listening.
Next.
I'm fine.
Any question?
No, I was judged at that time also in the preliminary round, so I've finished asking the questions.
So we give her thanks.
Yeah, thank you.
Thank you. Now go to the next presentation. Dr. Chaitra Jaydev.
Good afternoon, esteemed judges and my dear friends. Today I'll be speaking on some interesting insights into research that we've done at our institute. I have no financial disclosures. Well, 101 million diabetics are there in our country today, and at least 21 million of them already have vision-threatening diabetic retinopathy. So we are on the lookout for a very definitive treatment for our patients. We already know that vitreous biomarkers can not only predict disease, but it can also tell us the best treatment available for our patients. But sampling the vitreous is a little difficult. It's almost a surgical procedure. And we have tears, and we also have aqueous, which we can collect at the time of the first injection. And blood, every diabetic checks for their blood sugars. So that came about with this bright idea where we wanted to compare these 4 samples in the VAST study. We wanted to see if the biomarkers correlate between these 4 and how strongly do they correlate. 22 patients who were undergoing diabetic vitrectomy were recruited for this study, and all 4 samples were collected on the same day as the surgery. This was briefly how we did the study. Once they were collected, they were stored, they were segregated, and then extracted for further analyzing. We used different quantifiers, but we finally managed to get the absolute concentration in all 4 of them. As you can see here, the protein concentration was the highest in plasma, but we used something called as normalization to make all of them comparable. And if you see here, the ocular fluids biomarkers kind of group together. That's important because it probably tells us that organ-specific sampling is more reliable. Now coming to this is a very interesting cluster. If you see in cluster 2, it's called as hierarchical clustering, where we've seen these biomarkers coming together, which are both vasculogenic and inflammatory. So that means across the different 4 samples, they correlated very well. Overall, out of the 53 that we tested, 48 of them were positively correlating, and we found 80%, please remember 80% correlation between vitreous and aqueous, and also 28% between the 4 samples. This is a very busy Sankey plot. This is basically a complex interplay between the sample combinations and the sources. And the red arrows are the ones that are very important. We already know the usual suspects of VEGF and angiopoietin 2, but then we also saw a whole lot of other inflammatory biomarkers here, which could potentially be drug targets in the near future. Yes, we found it difficult to collect all 4 samples from a single patient on a single day across different disease spectrums, and we must remember that systemic variations will have a bearing. But then repetitive testing is possible, and sure enough, we will be able to find patient-specific therapeutic targets very soon. Well, this is the first study that has compared 4 different samples from a same patient, and also particularly in diabetics. We found the strongest correlation between vitreous and aqueous. We also found a reasonable correlation with tears because of extraocular spillover. We saw that organ-specific sampling may have definitely more clinical relevance, but friends, surrogate sampling is possible from a minimally or a non-invasive alternative like tears or aqueous. Let me show you this quick example. This is a patient with diabetic macular edema. We gave him anti-VEGF. You see that there is response, but the patient was not extremely happy, neither was I. So I pulled up his aqueous from the injection that we had during the first injection that we had collected. If you see, the VEGF levels are rather low, which is why intuitively I shifted this patient to a steroid and see the response. It's fantastic. Now look at this other patient. She's a 56-year-old female. She hates injections. The first thing she does as soon as she walks into my clinic is, "Doctor, please avoid the number of injections that my friends and family have received." So this is her biomarker profile. You would say that based on this, a steroid is preferable. So that's what we did, and look at the response. It's fantastic. The patient was extremely happy. Now imagine this situation that the same biomarker profile you can get even before her first injection, and that too from her tears or her blood. She would have been super happy. On the day of the testing, she comes, we check her biomarker, we give her something that she will respond better to. It could be an anti-VEGF, it could be a steroid, and then the patient would just respond fantastically at the word go. So friends, the future is very, very bright. We have a non-invasive and a repetitive biomarker that can not only monitor progression for our patients, but it can offer personalized therapy. We are on the brink of bespoke or personalized ophthalmology, dear friends. And with that thought, I'd like to end my talk. I acknowledge my entire team for this work, and thank you, judges, for your patient hearing. Yes, ma'am.
You have given a list of biomarkers, right?
Yes, ma'am.
Which among them is a take-home message for us?
This, ma'am, this list. This is the one that we saw a strong correlation with. So, and if you see, most of them are already drug targets, clinically relevant.
Biomarker that you translate into the
Yes, ma'am.
prognosis of the patient, which one would you suggest?
I would suggest VEGF predominantly because that's what we have most experience in, and with VEGF we've been able to already quantify, ma'am, in the different 4 samples, whereas the others, the quantification process is still ongoing. So currently, yes, VEGF, and then the pro-inflammatory biomarkers, that is the IL-6, IL-8.
And in the past, you have used vitreous, aqueous, serum and tears.
Yes, ma'am.
And which specimen would you prefer?
So based on this study, we saw the highest of 80% between aqueous and vitreous, ma'am, because they are more, closely related, and then with the tears.
You did the study on all patients undergoing
Diabetic
vitrectomy.
vitrectomy, so
Diabetic
22
vitrectomy.
patients.
And you then extrapolated the findings to help patients who are not undergoing vitrectomy.
Yes,
like
sir, only for the injections.
For the injections.
Yes.
Okay.
We wanted to make sure that what we are seeing in the aqueous actually reflects what is seen in the vitreous, because that's the most important.
Okay. Thank you.
Thank you, sir.
Dr. Pooja Kumar.
Yes, sir.
Sam Khamar, I'm sorry. For her
Thank-
presentation, External Eye and Ocular Surface Disease segment.
Thank you, sir, and thank you, judges. At the outset, none of the authors have any financial disclosures pertaining to this study. So we are going to navigate you through the worldwide impact of dry eye disease, the background and need of personalized intervention, the purpose of the study, and why do we need tear biomarkers, the methods on how to analyze these biomarkers, and how we can use these biomarkers for customized treatment strategies. So if you see on the left side of your screen, you can see how a healthy ocular cell would look like. But whenever they are under any stress, be it desiccation stress or inflammatory cells, they start losing the normal morphology and functions of the cell, and they start secreting excessive inflammatory biomarkers. And when we treat these 2 kind of patients, the set 1 patients are going to respond very well to our conventional in the first line of therapy, but the second set of patients are going to stay dissatisfied. They will try different treatment options, and they may seek opinions from a colleague, and at times they are still dissatisfied. So a non-responder in dry eye is the one who experiences persistent symptoms with objective measures like tear film stability or corneal health not improving as expected despite giving the recommended treatment plan. So the global incidence of dry eye is increasing, affecting almost 350 million people per year, of which 60% of the patients report having a poor quality of life in terms of their daily routine activities. And this does not affect the financial burden to the family, but to the global community as well. So we are at a stage that it's extremely crucial for us to identify the cause of this non-responder patients with advanced diagnostic tools and consider the customized therapy. So our question was, can we identify the root cause of why some patients respond to the treatment and not, and can we customize the treatment for these patients with the aim of providing them with tailored treatments? So our group has developed this BioM Pathfinder kit with which we can measure 8 biomarkers, both inflammatory and non-inflammatory, and this is an ELISA-based technology which uses the microfluidic system, which will give reliable and repeatable results. So you can use tear fluid or any ocular fluid. Tears can be collected using Schirmer strip. At the end of 5 minutes, you take it in an Eppendorf tube, add a patented buffer solution which comes to it, and shake the tube for 5 minutes. At the end of 5 minutes, you take the 50 microliters of buffered solution and introduce it into this well and put it into this analyzer system. At the end of 90 minutes, you're going to get this detailed report for each of these 8 biomarkers for each of the eye, whether they are normal or abnormal based on the reference interval. And you can choose the treatment for the same. So this study included 5,270 patients who visited our dry eye clinic. Based on TFOS due to classification, they were started on treatment. At 3 and 6 months, we did a dry eye matrix and a comprehensive dry eye questionnaire to find out the non-responders. And the non-responders were further subjected to tier biomarker testing using the BioM Pathfinder kit, and the abnormal biomarkers were treated with personalized biomarker-based therapy. 64% of the patients were non-responders to the first line of management in a tertiary eye care hospital, in which 27% patients had high MMP9, 17% patients had high ICAM1, and 20% patients had a combination of high inflammatory biomarkers. Based on one-fold, two-fold, or three-fold rise, they were treated on trehalose-based drops or a combination of trehalose and cyclosporin. And if this was a threefold rise, we added a vector pulsation therapy. And at the end of 6 months, the non-responders came down to 2.3%. Group which had high ICAM1s, it was 17%. They were treated with a combination of lifitegrast and trehalose. And at the end of 6 months, the non-responders rate came down to 0.7%. The group which had high IL-17 were treated with 1 sitting of vector pulsation therapy or 3 sittings of IPL. And the non-responders rate came down by 11.2%. And the group which had a multi-markers, inflammatory biomarkers which are on the higher side, 3 sittings of IPL therapy plus trehalose plus cyclosporin and doxycycline was incorporated. And post-treatment of 6 months, the non-responders rate came down by 0.6%. So cumulative non-responders rate from 64% came down to 4.4% with this targeted biomarker-based therapy. So incorporating a BioM Pathfinder kit into clinical practice will not only provide you with an immediate report, but also reduce the cost for the patients. And evaluation of 8 biomarkers might cost only 1,500 rupees. And moreover, this test can be conducted by a technician, and it is as small as a projector which can be kept in your clinic. So this is the biomarker kit which may help us discover and stratify abnormal levels of inflammation and have a targeted therapy for the same. And a more economical management can be provided by avoidance of multi-drug therapy in previous patients and avoid treatment failures. This CAT kit can be used for keratoconus, post-op unhappy cataract and refractive surgery patients, diabetic patients, and many more. And this is now available for use in clinics.
Thank and you. My team for helping me present this work on
Very
their
nice
behalf.
presentation,
Thank
Dr. Pooja. You have already mentioned that MMP9, ICAM, and the IL are the main biomarkers. Any new biomarker that you could find in your study?
So ma'am, what we have done with the kit, because it's going to be a clinically deployable kit, we have chosen the biomarkers which are common across dry eye and multiple other diseases like retinopathy, ARMDs, and vascular occlusions. So we have begun with those common biomarkers, and it has IL-17, IL-1 beta, IL-6, and VEGF. And it has IL-10, which is an anti-inflammatory marker. So it's a combination of 8 biomarkers. At this point of time, it's just 8, but as we move on, we will have more and more biomarkers incorporated in this kit.
So will this also help you differentiate onto the specific therapy that you want?
Yes, sir. So it will help. Yes, sir. So it will help us to, for example, a patient walks into my clinic. He's gone to 3 doctors and come to my clinic. He's not unhappy. So I can do the test, find out which of the biomarker is abnormal. Yes. Fresh patient also, sir, we can do the same.
You can do this, but how will it help you decide whether you want to go in for cyclosporin or you do not, or you want to go in for tacrolimus, or you want to go in for other? How does it help you differentiate as to what therapy to be? I'm talking of a fresh patient coming to you. So you're talking of a non-responder that I know that I've given cyclosporin, he's not responding to cyclosporin. So that's my only question.
So for a non-responder also, based on which biomarker is higher, we can give a similar treatment. For MMP9, the low dose, like if the MMP9 level is on the lower side, which is abnormal but on the lower side, a trehalose drop. If it's a 2-fold rise, let's say the normal range is 49,000, but my patient has 1 lakh, I will add a cyclosporin plus a trehalose for that patient. And if that patient has, let's say, 1,50,000 or 2 lakh, then I would add a vector pulsation therapy or an IPL therapy, which is available in my clinic, and that's why I stratify the patient. But if my patients don't have MMP9 higher, but my patients have IL-1 beta or IL-6 higher, then I know that cyclosporin or a trehalose may not work as a primary line of management. And that patient, even if I give a lubricant drop, tomorrow that patient is going to need a modern day dry eye therapy like an IPL or any vector pulsation therapy. So
Very
that's
nice.
how I can stratify in the primary place as well.
Thank you.
Thank you, sir.
So for the young ophthalmologist sitting in the house, It's time to accept and practice biomarkers and artificial intelligence in ophthalmology. We go on to the next speaker, Dr. Hitisha Mittal.
Good afternoon, everyone. It is a privilege for me to share our work on rescuing conjunctival lymphatics from mitomycin C-induced damage in rat model of glaucoma surgery. Now, one might wonder, why do these lymphatics need rescuing in the first place? During glaucoma surgeries, the conjunctival draining vessels are damaged, either due to cutting off the vessels or usage of intraoperative cautery, and the most important being application of mitomycin C during the trabeculectomy surgery, which not only damages the pre-existing draining channels, but also prevents their reformation in the post-operative period. A study published in 2021 used ocular surface lymphangiography in live humans and has demonstrated the role of lymphatics in fluid removal from the subconjunctival area. Another study published in 2016 evaluated the density of blood and lymphatic channels in eyes with leaking blebs post MMC trap and compared it with the normal human conjunctiva. They concluded that MMC has a toxic effect on these blood vessels and lymphatic channels, and all this leads to a defective fluid removal from the subconjunctival space, eventually causing bleb failure. This led us to wonder, can we induce lymphangiogenesis in the subconjunctival space, especially after MMC application? So on further literature search, we came across this molecule, retinoic acid, which is a biological active metabolite of vitamin A. It has been evaluated for its lymphangiogenetic potential in rat models of lymphedema. However, there were no studies available on its usage in eyes. So we devised a study to see the effect of MMC application on these conjunctival lymphatics and to see the reversal of MMC-induced inhibition of lymphatics by simultaneous application of retinoic acid. It was a prospective experimental interventional study done on 25 Sprague Dawley rats, which were divided into 5 groups. The right eye in all the groups was the intervention eye and the left eye was control. We used a 30-gauge needle to inflict injury in the subconjunctival space and formed a superior subconjunctival bleb, which was according to each group specification. In group A, we used balanced salt solution. In group B, we used MMC. In group C, we used the 100 nanomole concentration of retinoic acid. In group D, we combined MMC with retinoic acid. And group E was the dimethyl sulfoxide group. This DMSO is a diluent for reconstituting retinoic acid, and we wanted to rule out any confounding effect of DMSO on lymphatics. Hence, this separate group was devised. On post-op day 14, the eyes were renucleated and sent to pathology lab for staining with Mason trichom, CD31, and D240, which are the vascular and lymphatic endothelial markers respectively. And we saw what was the fibrosis, lymphatic, and vascular density. Now coming to the results, these are the histopathological slides. In the first image, we can see this is normal conjunctival tissue, and the arrows marked show here the normal conjunctival lymphatics. In the second image, we can see there is an increase in the number of conjunctival lymphatics when there is a localized injury with balanced salt solution. In the third image, we can see there is a decrease in the number of conjunctival lymphatics in the MMC-treated eyes. The fourth image shows a dramatic increase in the conjunctival lymphatics when MMC was combined with retinoic acid. This table shows and highlights the fact that the mean lymphatic count was higher in the combined MMC and retinoic acid group when compared to the MMC-treated eyes. The first graph here shows the intra-group analysis between the intervention and control eye. We can see MMC has a significantly lower conjunctival lymphatic count in the intervention eye when compared to its control. And the combined MMC retinoic acid group had a higher conjunctival lymphatic count in the intervention eye when compared to its control. Similarly, on intergroup analysis, we found the combined group had higher conjunctival lymphatic count when compared with the MMC-treated eyes. So, MMC resulted in significant reduction in conjunctival lymphatic density. 100 nanomole concentration of retinoic acid significantly increased the conjunctival lymphatic density, not only when used alone, but also in the MMC-treated eyes. So we conclude that synthetic retinoic acid prevents MMC-induced reduction of lymphatic vessel density in rat eyes, and it has a potential application in preventing or reversing the MMC-induced complications of glaucoma surgery, and thus improve our surgical outcomes. I would like to thank my mentor, Professor Pandav sir, for guiding me throughout this study, and AIOS for this opportunity. Thank you so much.
Thank you. See, we have been using MMC since the last 2 or 3 decades now. Yes, for glaucoma surgery.
Yes, sir.
And even assuming that what you're saying is right, that it has a bad effect on the lymphatics.
Yes, sir.
There has been the success rate of a trabeculectomy with MMC has been pretty high.
Yes, sir.
So is there a need to use something else to counter the effects of MMC?
That was the whole aim of this study. So we cannot discourage the usage of MMC because there's a reason why it came into practice. So we wanted to know whether we can add something to the ongoing practice, and according to our study, retinoic acid shows that if we add retinoic acid during the intraoperative time, it may actually counteract its negative effects, and we can happily utilize its positive effects, that is preventing the subconjunctival fibrosis postoperatively. So for now, this is an experimental study, and retinoic acid is yet to be used in humans. It has been used in mouse tail lymphedema models. Actually, it was being investigated by a different set of specialists. We came across this study and we thought we can maybe connect the dots together and promote a future possibility of research in this area.
Any study?
Exactly.
Yes, sir, but retinoic acid is commonly used by our dermatologists for treating a lot of dermatological conditions. So there is a possibility that it's less likely to have toxicity because it's already being used on the human body. It has not been used, so we are the first one to use it.
Any study to quote failure of BLAB following use of MMC intraoperative?
Yes, sir. I've shown one study. There are multiple studies, actually. The one I used had the largest sample size. They took normal conjunctiva from normal humans, and they took their leaking bleb patients, which were post-RAB MMC. And they had said that the conjunctival count was...
Congratulations. It's really an innovative study because the role of MMC also for the ocular surface has come down because of this problem that you have mentioned.
ma'am.
So you're trying to work on it. It's really nice.
Thank you so much, ma'am. Thank you, sir.
So we go on to the next speaker, Dr. Oja from lacrimal segment. And I request Dr. Jyoti to be ready on the dais.
Slides. Yes. Good afternoon, everyone. My topic is the role of mobile endoscope in lacrimalology. As we know, lacrimalology is science that deals with the lacrimal system of the human body. Lacrimal system incorporates both ophthalmic and nasal system. Ophthalmic part consists whole lacrimal system except NLD. Nasal part consists nasolacrimal duct. So we have to successful management of the any case of the epiphora, we have to rule out the nasal pathology like nasal polyps, nasal synechia, DNS, या hypertrophied middle turbinate. To rule out the nasal pathology, what we are doing now in the traditionally we are doing in the OPD nasal speculum examination, but limitation with the nasal speculum examination is the restricted field of view. Up to anterior nares we can only examine and not able to document a counseling to the patient. We can't save the pictures and cannot show the pictures to the patient and attendants. Then we are taking, if we are not able to do in the OPD, then we are taking patient to the OT and doing the traditional nasal endoscopy. But here is also limitation. Limitation is this system is the non-portable. Here LED system and endoscope, it can't port anywhere. And another thing is it is expensive compared to our mobile endoscope. So that we come for the mobile endoscope, which is now usually used as the otoscope in the market. This is the pin-like LED mounted camera, which is attached by the mobile through the USB port. You can attach it to the mobile computer. You can save the video, you can save the image, you can document it, you counsel the patient and attendant also. And it has the benefits, it has the wide range of view, it is able to document, it is portable, pocket friendly, and it is very cheap. And so our purpose, so then we have tried to find out the usefulness of this endoscope in dacryology for diagnostic and therapeutic purpose. So that we have done the observational study in our institute with the patient of the symptomatic epiphora. Then we have divided the patient into the two parts, diagnostic purpose and therapeutic purpose. Diagnostic purpose, we have selected 31 patients. Among the 31, 18 is the female, 13 is the male. And out of that, 25 examines in the OPD and 8 examines in the OT. Average age is the 52 years. And after that, second part is the therapeutic purpose. We have taken the patient of the failed DCR and CNLDO for the examination. Number of all these patients are 8. Among them, 5 is the female and 3 is the male. And out of that, 4% of the CNLD or 4% of the failed DCR. This is the short video how we are examining in the OPD. We are doing mobile endoscopy in our OPD. Prior to endoscopy, we put the Xylocaine nasal spray, and then we do the endoscopy by the mobile endoscope. We put the mobile holders and attach the USB port to our mobile and examining up to the middle turbinate. We are not able to examining the superior turbinate because this is the limitation of this scope. We are not able to go to the inner side because its handpiece is short. Handpiece is not very long, so we can't able to go to the upside. And its image quality is little bit down compared to the traditional endoscope. And what is the result? Diagnostic purpose, we get the result. 20 cases is within the normal limit, 5 cases is roomy nose, 8 cases the DNS. All DNS cases we are, OT screening we have done, and out of that 2 cases nasal synechia, 3 cases are severe DNS, and 3 cases we are not able to do. And the result side, therapeutic purpose, failed DCR, 1 cases we are able to manage by the mobile endoscope, 3 cases I have managed by the traditional endoscope. And for CNLDO, 2% we are able to see the probe, and 2% we are not able to see by the mobile endoscope. Then conclusion. Conclusion is divided into pro and cons part. First of all, important is cost effective, so that every ophthalmologist can try to do, learn the endoscopy. Second one is the portable, even can do the nasal screening in the remote campaigns, and it is better alternative of the traumatic traditional nasal endoscope for screening and pre-op examination. Cons is its image quality is not good as the traditional endoscope. It is limited use of the therapeutic purpose and need to do more observational study by different hands to understand its usefulness in the cryology. Thank you.
Other than the cons you have mentioned, what other limitations this procedure has got?
Limitation
compared to ophthalmic DCR or external DCR.
External DCR, this is not, we are talking about the external
What are the
DCR.
limitations of the procedure you have highlighted?
Yeah, this is arm is very short, sir.
No, I am asking for clinical limitations.
Clinical limitations?
Yes.
Yeah,
it is of no use in punctum strictures. It is of no use in canalicular blockage.
No, sir. We have shown the nasal evaluation. We are going to nasal evaluate every case of the DCR.
So first you will refer the case to your ENT.
No.
You will do it yourself.
Yeah.
Okay.
So this is the helpful for everyone.
My issue is that in the few number of cases that you showed 50% were normal, your examination, and you had deviated nasal septum.
Yes, sir.
Now, deviated nasal septum, you don't need a modified otoscope to see. I mean, you just put a 30-cum speculum and you can see the deviated nasal septum.
Deviated is we put the speculum and we do the screening in the OT, sir.
No, even in the OPD, if you just put a 30-cum nasal speculum
yes,
and put a torch, you can see a DNS.
We can see, but not able to document counseling, put the image in the archive for the patient and others. They are always
for
telling
documentation.
That yes, sir.
Okay,
for
fine.
the documentation is very important.
Thank you.
If any problem, we can show to the patients. This is the DNS. We are just retract by the speculum, and then we are able to see your inner side. Your nose passage is very narrow. We put the video in the archive, and if any problem, we can show to the attendants and patients.
Do you get a X-ray PNS done? X-ray PNS done as a preoperative, for evaluation?
X-ray PNS, not every case.
It is not required. I hope you keep attending ENT annual conferences also. Thank you.
Thank you, sir. Thank you.
We go on to next speaker, Dr. Jyoti from Neuro-Ophthalmology segment.
Yeah, good afternoon all. We are aware that raised intracranial pressure causes papilledema and this causes significant vision loss. So it's important that we have to reduce the ICP. Now in certain cases you need an optic nerve sheath fenestration to relieve the compression on the optic nerves and thereby preserve or improve the nerve function. But what happens if there's an atrophic papilledema, relatively flat nerve head and failed nerves? In this, can we do something? So this was a research question where we want to report our experience with optic nerve sheath fenestration for visual loss in those with atrophic papilledema. It was a retrospective interventional study over the last 10 years, and we found 48 eyes of 27 patients which having this disease. They followed the normal protocol, and each of this was analyzed for our study. And we included only those cases which had a raised ICP on maximum treatment with the presence of disc pallor with or without disc edema. But the B-scan classically showed the subarachnoid fluid with the hypoechoic crescent confirming that it's a raised ICP. All these patients had undergone optic nerve sheath fenestration by the medial conjunctival route by me. We looked at the outcome measures with terms of the visual acuity, the visual field, improvement in the central field, and disc edema, whether it was persistent or completely resolved. These were the 48 eyes of 27 patients, and what we found out, 21 eyes, that is 44%, had clinically flat discs seen on fundoscopy or on OCT. About 50% of them had raised ICP due to idiopathic intracranial hypertension. As you notice, all of them had enlarged optic nerve sheath, which resolved after surgery, and they had visual fields which were completely constricted, done only in 17 eyes, and we had all about minimum 6 weeks follow-up. So these were the surgeries done. We had two groups, one is unilateral and the other one is bilateral. Of the 6 unilateral eyes, we operated the 6 patients. We had 4 patients having good vision, so we operated the worst eye. Among those with poor vision, 1 patient had relative vision in the left eye, so we operated that child. And 1 with no PL, we operated one of them. Among the bilateral, we had 42 eyes. Of this, 12 patients of 12 eyes of 6 patients had vision from 6/6 to 6/60. In the poor vision, we had 16 eyes of 11 patients with counting fingers close to face and 5 meters, and 14 eyes of 7 patients with either hand movements, PL or no PL. So among our results, all patients with good vision did well, either improved or stabilized, and visual fields did improve. Now, those with poor vision were stabilized in both the groups and even improved, but had some ambulatory vision. But those with no change was noticed in those with significant vision loss. So let's look at one patient who had good vision in one eye and poor vision in the other eye. As you can see, 618 parts, and these were flat discs. If you look carefully, this completely constricted optic nerve, the field showing that he was completely blind. And if you look at the discs on OCT, they are flat. So many a times, this patient has refused surgery elsewhere when he came to me. And if you look at his B-scan, there's significant fluid around it. And we went ahead with surgery. Look at the cotton peanut. It is right at the place of the optic nerve sheath. And if you look carefully, this is so much ballooned. And when we go in the medial conjunctival space and make a nick on the optic nerve sheath, see the amount of fluid. So this patient has significant fluid. This is a decompression technique that we done, which is followed by making a nick inside and removing a part or the window of it. That is a fenestration. So the pre-operative B-scan, which showed the SAF after surgery, was completely resolved. And this patient is now 18 months later had improved vision. So many a times they come with flat discs but have a deteriorating vision and therefore need surgery. So coming back to our summary of results, so we had 48 eyes, of which 24 eyes had vision better than 6/60, all did well. We had 10 eyes with vision less than 6/60, of which counting fingers close to face to 5 meters, they had ambulatory vision, but with poor vision cases did not change at all. So in summary, 34 eyes, that is 71%, with a vision of at least counting fingers close to face to begin with, maintained ambulatory vision in all these patients, with 23% having an improvement and 48% having resolution. The complete resolution was noted on B-scan in all of them. The disc flattening starts about the first week and gets completed by 4th week. Fields improved in about 17 cases, either as stability or complete improvement, but there was no vision-related complication. What we already know is that there is ONSF definitely works, and it is about 80%. But what we don't know is that there is no atrophic papilledema ever considered in these cases. So what this study tells us that it is the first study talking about atrophic papilledema, and it's a must in these cases. Early ONSF will help salvage vision even in pale and flat discs. And B-scan is an important tool to find out whether we should intervene or not. Remember, there's no role of ONSF if the vision is either hand movements, PL or no PL. But if there is counting fingers at least close to place, we should do it to get ambulatory vision. We as ophthalmologists must understand that to prevent blindness in these patients, anybody can do this surgery if you do it at the right time to prevent blindness related to a disease which the neurologists and the neurosurgeons handle. Thank you very much.
Very nice presentation, Dr. Jyoti. I have few questions to you.
Yeah.
You have taken all cases of vintage papilledema, those atrophic papilledema. So have you checked the opening pressure? Because we know the chronic papilledema is one of the cause for this.
Yes.
So what was your opening pressure which helped you decide the surgery?
So all these patients had a high opening pressure. Some of them were IIH cases, some were cerebral venous thrombosis. They were managed completely by the neurosurgeons.
No, I mean the CSF opening pressure.
Yeah, CSF was more than 300. 30 millimeters, 300 millimeters, 30 centimeters of water.
Okay.
This concept of atrophic papilledema is coined by you, or it's
No,
in
it is a known,
literature?
it's a known entity.
It's a known
Yes.
entity.
So what happens is papilledema have 4 grades, of the 4th being atrophic. So when it's atrophic, the discs appear flat. So people feel it's flat disc, there's no need to operate. Anyway, the discs have resolved. But what happens is behind there, this is the SAF, which is communicating, is still causing the whatever vision left in that optic nerve to further deteriorate, and then they go into no PLPL. So if we catch them at that time, we can at least salvage that ambulatory vision.
Second question, have you started with any oral medications before? And
Yes,
for
we
how
have.
long you have waited?
So they wait for at least 6 months. So it's not only about waiting. We monitor each of them in terms of the vision. We look at the visual fields. If any deterioration is noted, we keep on a longer follow-up. But anything less than 5 degree of constriction of the fields or vision dropping less than 6/18, only then we intervene.
And what was the dose of the acetazolamide that you've given?
If we give as high as 2 grams.
2 grams per
Yes.
day.
Yeah.
Okay. And you have operated on one side or both the sides?
No, that I said 6 were unilateral. Rest of them, where there are no PL hand movements, I want to give benefit of vision to all of them, so it's bilateral case.
Was the medication continued after the
Yes. So what we have to understand, I have just salvaged the optic nerve, but the treatment has to continue with the neurologist and the neurosurgeon because the problem is in the brain, not in the eye, so that should continue.
Thank you, Dr. Jyoti.
Thank
I
you.
appreciate your confidence. We go on to the next speaker, Dr. Jai Gopal. He is from Optics Refraction. I'm sorry. Dr. Usha. Oh, jump ho gaya. Kya baat ho gayi?
My paper is on
My regrets for that. I invite Dr. Usha for her presentation.
Thank you, respected teachers. My paper is on SMS strategy for molecular diagnosis of retinoblastoma. As we all know, the diagnosis of retinoblastoma is clinical. Radiology provides presumptive diagnosis, and histopathology can give a definitive diagnosis post-enucleation. So sequential molecular screening of RB is available only in few centers and is very expensive, which remains a bottleneck. Hence, we aim to develop an indigenous and cost-effective method for the molecular diagnosis of retinoblastoma. The methodology we used was DNA is isolated from the blood and tumor samples wherever available using the suitable kits. The quantity and the quality of the isolated DNA is checked by the qubit fluorometer and the agarose gel electrophoresis. Sanger sequencing and multiplex ligation dependent probe amplification, that is a MLPA, is used to detect the point mutations and the deletions or duplications of the RB1 gene. Both the steps involve the amplification of the gene or the probe that binds to the gene, which gives us about 90% sensitivity. In addition, we do methylation specific MLPA for detection of the promoter methylation in RB1 gene, which gives about 95% sensitivity. Next generation sequencing methods for the targeted whole exome sequencing were also done to detect the single nucleotide variations, that is the SNV, and the copy number variants in additional genes other than the RB1. Library preparation using the specific kits was done in-house. Data analysis was done as it is very critical to identify the suitable variants, which are population specific, person specific, structural specific, and functional specific. So this is the channelized flow of the sequential molecular screening of retinoblastoma with integration of data and functional analysis. And this is the flow. And with all the methods and high throughput instruments in place, we complete the analysis starting from sample collection to report generation in just 3 weeks. So genetic analysis and counseling has benefited 543 families with retinoblastoma. That is, we have analyzed 2,120 samples. Patients with mutations, that is germline, were 305, forming about 56%. Patients without mutations, which was sporadic, forming about 44%, that is 238. And families with mutations was 41, forming about 7.5%. If germline, their future siblings and offspring have to be checked clinically and genetically for RB. If there's no mutation in blood, RB will not be inherited. So more than 100 mutations like nonsense, missense, frame shift, splice have been identified, out of which 20 are novel, and these mutations are being characterized for their pathogenic role. Promoter methylation was identified in 4 patients, tumor, but not in blood. This epigenetic event is somatic. They're less likely to inherit the mutation to the next generation. You can see a unilateral RB without any family history was found to have a promoter methylated in both the alleles in the promoter region. MICin is a well-characterized gene of RB. Increased copy number of MICin was demonstrated in several cancers. MICin amplification with more than 10 copies was detected in 3 of our patients, correlating with the severity of the disease. CNV analysis of unilateral RB tumor samples was validated and confirmed by the qPCR. Our next generation sequencing analysis has identified several candidate genes involved in the tumorogenesis. We found the gene modification amplifications in MDM4, K1F14, DEK, E2F3 and TP73. These genes are involved in cell cycle regulation, cell proliferation and apoptosis. Currently, we are studying the role of the individual genes through cell culture models and trying to identify the suitable drugs to reduce the expression. The impact of this study has been seen for 543 families where the timely and cost-effective diagnosis have helped them in making informed decisions by predicting the possibility of RB in the sibling, offspring, laterality and secondary cancers as well. Cost has been reduced from $1,800 to $150 for an entire family, and the time from 10 weeks to 3 weeks, which can further be expedited. Thank you very much.
Thank you, ma'am. You have a question? Sure.
Very nice presentation, Dr. Usha. You have done both the genomic and the exomic sequencing.
Yeah.
Did you help in any prognosticating the disease?
Yeah, that's
Because
what I was...
it's quite expensive doing both, right?
Yeah, so it's not within the purview of this, but we have seen that MECAN amplifications have had a prognostic indication as well. So we are able to predict and preempt for the sibling, the offspring, and also prognosticate if the patients who are undergoing radiotherapy, which is still a part of the treatment regimen, will ever get a secondary cancer, which is quite common with the... Thank you.
Dr. Jay Gopal Agarwal for his presentation.
Good afternoon to everybody. And my presentation is for excellent refractive outcome. Is artificial intelligence-based IOL calculation emerging trend over the current practice? I have no financial interest. The purpose of this study is to compare the accuracy of widely used IOL power calculation formulas, including the artificial intelligence-based formula. There are two groups as shown in the slides. The first group is artificial intelligence formula, where there is a Hill RPF, Ladas and Kane. And next is the regression formula, includes also the Barrett's, Oleson and EVO. For either a retrospective study and the IOL master 700 readings are being is taken, and the patient is distributed into groups in the terms of their axial length. Group 1 is more than 24, equal or more than 24.5. Group 2 is between 21.5 and 24.5, and group 3 is 21.5, that is hypermetropic. Preoperative, post-operative is also calculated with what the best corrected visual acuity, post-operative actual bidioptric power and the number of dioptric errors. These are my inclusion criteria, and this is exclusion criteria. These are data collected from all my patients, for every types of eye, that is normal, short and long. The refractive mean calculation error and mean absolute error of IOL formulas of different axial length and group are calculated and compared. Refractive error of absolute value by percentage of each formulas is calculated 0.25, 0.5 and 1 diopter and 2 diopter. The mean absolute error is used to is an indicator for the IOL formula prediction error. Small standard deviation of a small mean absolute error shows the accuracy of the prediction is very good. Centroid residual astigmatism prediction error are calculated for each method where we opt for the traumatic IOL. In this series, it is 26 cases. This is the demographic and the preoperative biometric ocular parameters of the patient. I have calculated the mean numerical errors for different formulas, and it shows that the artificial intelligence-based formula is the least mean numerical error. Similarly, in the mean absolute error also, the Hill RPF, Ladas Super and other artificial intelligence-based formula is the least mean absolute error. And the sensitivity of the formula prediction at 0.25, 0.5 and 1 and 2 diopters here again, the artificial intelligence-based formula, that is Kane, Ladas formula and the Hill RPF gives the minimum post-operative error with more eye within 0.5 diopter of spherical equivalent. The same thing is shown in the table from my data. The mean absolute error is the smallest in ladder super and Keynes formula, followed by Hill and Barrett and other formulas. Ladder super formula and Keynes formula predicts the more eye within the 0.5 diopter of spherical equivalent. For the toric IOL calculation, we use artificial intelligence-based formula for the spherical part and the Barrett toric calculator for the cylindrical part. For the post-elastic calculation, no artificial intelligence-based formula still now. Here it is centroid error is calculated. For the centroid error, I have calculated artificial intelligence formula for the spherical part and the Barrett for the toric part, and thus adding this result, it gives the very good result, and it gives more accurate than the other formulas. For the extreme eye, we have already grouped in the long eye and short eye. Here again, the Keynes formula and ADA super gives the excellent result. This is my data collected from my study for the short eye. Here again, the mean absolute error, median absolute error, and the maximum number of cases, 0.5 diopter is better than better in the cases of Keynes and artificial intelligence formulas. This is a study by the Chang that gives the almost same result. To conclude, Keynes and artificial intelligence formula is a single answer for any IOL power calculation query. Artificial intelligence formula is totally data-driven, artificial intelligence-based pattern recognition without estimating the expected lens position, and it is continuously evolving, thus becoming more and more accurate, and accuracy above 90%. Keynes and artificial intelligence formula being the game changers in biometry. Though the Barrett formula is used very commonly, here the calculation of expected lens position is inbuilt and very accurate. It is important that newer formulas, especially for the extreme eyes, Keynes, Hill RBF, and Ladder Super should be used. For the toric IOL calculation, online Barrett calculator is a good choice. Thank you for your kind attention.
Thank you, Dr. Agarwal. I would like to see comments from Dr. Mahipal, who himself is a master IOL surgeon.
I'm not a calculator. I can be a surgeon. Anyway, good presentation. I think it's a good indigenous attempt to get another formula on the armamentarium and maybe confuse all of us a little more. Anyway, I think it's a good thing, but it will have to stand the test of time as to whether it's actually giving us better readings than outcomes on that.
Keynes formula especially should be validated. Because it gives more, you want more study from that.
Yeah, that's what I'm saying. So more people have to get into this formula, and would you make it?
For extreme eyes, long eyes and short eyes, artificial intelligence formula is better than the.
Yeah, I understand that, but will you be making this available? Are you patenting it, or it's open source?
No, it is from only from my study.
Sorry?
AI is not yours.
Yes.
No, this is open source.
Artificial intelligence, is it going to be open source or?
Yes, it is open source.
Open source.
Open source.
Thank you, Dr. Agarwal. We go to the next speaker,
Thank you.
Dr. Pratibha.
Respected judges, teachers, and my dear friends, very good afternoon. I'm Dr. Pratibha Devi Nivian, and I'm here today to present on-tier biomarkers in thyroid eye disease, the first Indian study. Thyroid eye disease is a very complex autoimmune disorder. Understanding about the pathogenesis is evolving. We know that the immune dysregulation in the orbit causes antibodies to self-antigens that in turn causes multiple reactions inside the orbit, causing either a fibrotic disease or a fatty disease. We know the TED presents in varied presentations from a simple mild lid retraction to a gross disfiguring proptosis with dysthyroid optic neuropathy and exposure keratopathy. What do we do now for such patients? We treat based on the inflammatory scoring by either the clinical activity scoring or the visa scoring, and we treat them with steroids, immunosuppressants, radiotherapy, and targeted therapies, whichever is available with us. But what is lacking? We treat after the disease is well established. And most of the audience here would agree with me that treating an active thyroid eye disease is very challenging as well. So what could be ideal? Identify a patient who will probably develop a disease, an active disease, and treat them before they develop a full-blown disease would be an ideal thing. So how can we identify such patients? To look in for biomarkers from various human tissues. Tears could be an ideal source as it is in direct contact with the eye, the lacrimal glands are affected, and the tear fluid is easy to procure and it is extremely non-invasive. So with this background, I did some literature search and I did find so many researches done on this aspect, and that one particular article from the Biomolecules Journal had compiled a meta-analysis on this particular thing, and most of the authors have proven that few of the interleukins, the inflammatory markers, are raised in TED. With this background, and since there was no study done in India, we aim to look for significant markers in tears in TED. My study was a pilot study done prospectively after ethics clearance. We diagnosed TED based on Gorman and Bartley's criteria. We did the activity score based on the visa scoring, and severity was assessed by UGOGO. We took tear samples from 2 tertiary care centers with Schirmer's tip methodology, and storage was followed meticulously in both the centers, and the sample was analyzed in another tertiary care center lab with proper protocols followed, and we collected samples from healthy controls, patients with TED and patients with thyroid eye disorder but without TED. We excluded patients with other systemic and ocular disorders and not willing for the study. We performed the multiplex ELISA, and we did study the inflammatory markers which have been proven to be affected in TED. Our study had 19 patients with TED and 13 controls and 11 patients without eye disease. We had 11 patients in the active disease group. This was the gross result which we got from our study. We found most of the inflammatory cytokines were elevated. However, interleukin 6 and interleukin 10 were significantly elevated in TED group, suggesting they could be potential markers to induce an activity, or they could be even a good prognosticative marker to look in for relapse of the disease. And we also noticed that interleukin 6 was, the activity was a strong risk factor for increase in IOP, and we did notice that IOP was directly related to dysthyroid optic neuropathy. Interestingly, we also noticed that in literature, antagonist to interleukin 6 was used for treatment of thyroid eye disease. Randomized control trials have been done, and they have successfully proved to treat the active thyroid eye disease successfully. And we did notice that there are a lot of targeted therapies available for the treatment of active thyroid eye disease. So what could be the future? The biomarker detection can give us a clue as in who would succumb to the disease, and to look for potential markers and treat them with specific antagonist even before the activity scoring is 4 or more could probably avoid the high dose of steroid treatment. And this could also be one of the prognosticative marker, and to look in for a relapse in patients, most importantly in a very non-invasive manner. So to conclude, tear biomarkers can be a promising clue to diagnose patients at the risk of developing sight-threatening complication in TED. As already discussed in other specialties, also these biomarkers are in vogue. So these are my acknowledgements. These are the people who helped me throughout the study, and thank you for this wonderful opportunity to present in this great session.
Can I ask a question?
Yes, sir. Yes, sir.
IL-6, as you know, is an inflammatory biomarker.
Exactly.
And IL-10 is often seen in the lymphoma when IL-10, IL-6 ratio is elevated. You have seen both IL-6 and IL-10 elevated. How do you explain?
Yes, sir. Interleukin 6 is an inflammatory marker. Interleukin 10 is an anti-inflammatory marker. The body always has, probably this is the thought process in my mind. When there is an antigen, the body always increases the antibody production as well. So when the inflammatory marker also increases, probably the body also tends to produce the anti-inflammatory marker also more.
Did you look at the IL-6, IL-10 ratio?
In this particular study, I have not currently analyzed that, sir, in this particular thing.
In the same line, I would like to ask you, these are basically biomarkers of inflammation, right?
Yes.
So because we know that thyroid eye disease is associated with dry eye disease and other inflammation. So is this biomarker specifically targeted to thyroid or due to the dry eyes and the inflammation that we are having?
Both in thyroid eye disease and in dry eye disease, the basic pathogenesis is inflammation. So we are only targeting the inflammation with specific anti-inflammatory agents, the targeted therapies.
Thank you.
Thank you.
So biomarkers again, please remember. We go to the next speaker, Dr. Chavi Gupta from Orbit and Oculoplasty segment.
Good afternoon, everyone. I'll be presenting my paper on a novel and inexpensive training model for teaching basic steps of oculoplastic surgery. So we all know that ophthalmic surgical training has a steep learning curve where large numbers are required for increasing stepwise surgical competence. And the Halstead's model of see one, do one, teach one, there the patient safety is at risk along with ethical concerns. We do have wet lab and simulators as training model, but nothing specific for the oculoplasty procedures. And there are some must-know procedures that are present there for the residents and the general ophthalmologists. So the aim of the study was to assess the utility of pig head as a potential surgical training model for surgically naive trainees for practicing basic steps of oculoplasty like upper lid entropion surgery, evisceration plus minus implant, and lid margin tear repair. So the methodology involved procurement of the pig head from the arbiter, establishment of the surgical workstations in the already present wet lab, didactic lectures and video demonstration of the surgical steps to the trainees, and step-by-step guidance and supervision by expert oculoplasty surgeons to the trainees. But how to assess the performance? So we had divided all the steps of the surgery into cardinal steps. Like you can see for upper lid entropion, it involved traction sutures, tarsoconjunctival incision, dissection, and then the everting mattress suture. And similarly, this was the response of the training. And similarly, further surgeries were divided into their cardinal steps. The upper are the human eyes and the lower are the pig eyes. So this was similarly done for the lid margin repair. So how to assess subjectively? We developed a Likert scale-based questionnaire. One was for the mentors to evaluate the trainees, how they are performing the step, whether they had any difficulty in performing or could not perform at all. And for the trainees, we had for the tissue feel, improvement in skill and understanding of the surgical steps. And for the objective assessment, especially for the entropion correction surgery, we had a surgical competency-based rubric which was vetted and validated. It consisted of 5 key steps of surgery and 5 global indices based on the modified Dreyfus model with numerical tracking and descriptive narratives. The scoring of the performances of the trainees was done, and we also had translation to OT, where 3 of the participants performed the surgery on real patients, and the same rubric was used for performance assessment. So we had 18 participants, which consisted of residents and ophthalmologists. 83.33 had neither observed or assisted these surgeries. And this was the performance-based assessment where the steps had been performed by the, this is the subjective performance assessment. So here you can see the performance of all the participants for entropion correction, for evisceration plus minus implant, and for the lid tear repair. So the validation process, the median score was 4. In the participants, they achieved a score of 3, and in the OT, they achieved a score of 4. They also overcome the various hurdles, and 100% participants felt that the practice improved their surgeries, and 95% almost felt that they had a better understanding of the surgical steps. So this can form an ideal model because of the similar anatomy, easy storage and acquirement, inexpensive, and low risk of disease transmission. They have been previously used for some oculoplasty surgeries and for glaucoma and cataract surgical training. The advantages of pig model are they are affordable and available, and they have a larger size compared to other animals. Our participants also felt similarity in the gross anatomy, and also in the tissue maneuvering, and the texture was similar. Compared to the human eye, there are multiple differences, but the skin being thicker can be managed with the help of larger free cutting needles. There is no bony orbit that is present. There is a semilunar fold of skin and the presence of the retractor bulbi muscle. So I would like to conclude that the porcine model is affordable, usable, and achievable even in a resource constrained training environment, recommended for early training, and it can improve the anatomical understanding, clinical judgment, and surgical efficiency. And also this rubric of upper lid and tropion can be used for future application and be utilized for assessment of the trainees. Thank you so much.
Thank you, madam.
These
It's
are
a
my
novel
references.
idea to train our younger doctors in oculoplasty segment, because we all realize that problems are on rise where services of oculoplastic surgeons are required. So, any other comment from you?
Very nice way of teaching and training.
Thank you,
So
ma'am.
who are the participants? Like they are the residents from different parts of
Ma'am,
your,
they were
or
the
your
residents,
own students?
DNB residents from our institute, and also the participants. We had conducted a workshop where these general practitioners were invited.
That's my question, because you have mentioned that performance have increased, the performance percentage has increased.
Yes.
So how do you monitor the efficacy of this increased performance in those residents who are not from your institute?
Ma'am, we
Because
have not
overall
yet,
percentage you have shown quite high.
ma'am, so that was the surgical stepwise performance. So where we
Now
have
once they
taken
have
this-
gone back and started on human tissue.
Ma'am, we had that subjective questionnaire. So there it was on the Likert scale base. So the steps that they have performed without any difficulty, that percentage has been incorporated into the graphs that I've depicted.
Thank you.
Thank you.
We go on to the next speaker, Dr. Vaishali Vasavda, for her presentation from pediatric ophthalmology segment.
A very good afternoon to all, and we have no financial interest on this 7-year report of postoperative outcomes of IOL implantation in the bag and anterior vitrectomy versus optic capture of IOL without anterior vitrectomy in children below 4 years of age, a randomized clinical trial. Now, we all understand that performing anterior vitrectomy and anterior and posterior capsulotomies and then putting the lens in the bag is the standard of care for most children below the age of 5 or 6 years. Now, what if we can avoid this anterior vitrectomy? So we wanted to look at in the bag IOL and anterior vitrectomy as a standard method and optic capture of an in the bag IOL without performing anterior vitrectomy, and all this makes sense only in the long term. This was a prospective randomized control trial we started several years back in Ahmedabad. 61 eyes of children with congenital cataracts below the age of 4 years without any anomalies were included. Now there were two groups, 61 eyes randomized to group 1, where like I said, anterior posterior capsulorhexis manual with limbal anterior vitrectomy, and in the bag 3-piece hydrophobic acrylic IOL. In the group 2, everything else was the same except for two differences. One, a 3-piece IOL, the same one was placed in the bag, and then the optic was captured behind the posterior capsulorhexis, and no anterior vitrectomy was performed in a planned manner. A standardized technique was followed and a 3-piece hydrophobic acrylic IOL was done. Standardized follow-ups, including EUAs whenever were necessary, were taken, and this report includes at least 84 months of follow-up for all eyes. What we were actually looking for, basically 3 things: visual axis obscuration, VAO, which needed intervention within this 7-year follow-up, glaucoma, as well as inflammation assessed in form of cell deposits, and posterior synechiae. So when we look at the preoperative demographics, we had 30 and 31 eyes in each group. The mean age in both groups was, in one group was about 18 and the other was about 15. But it's important to note that in both groups, about 45% eyes were below the age of 1 year at the time of surgery. The mean follow-up in this cohort was 95 months, and both had about a similar follow-up. But what I do want to highlight, that with free follow-ups, with so many calls, with no charging, still at least 25% eyes in both groups could not finish the 7-year follow-up. When we looked at intraoperatively, in 3 eyes out of the 31, we could not do a capture, and in 2 of these we had to perform a vitrectomy because there was an inadvertent rupture of the anterior vitreous face. Looking at the post-operative outcomes, in both groups there was at final follow-up, there was a good improvement, 0.6 logmar on distance visual acuity, and not significantly different. When we look at how many eyes needed a procedure for visual axis obscuration, in the bag and vitrectomy 3 eyes versus no vitrectomy and capture group 2 eyes. Comparable, but what I'm saying is there is no difference. And all the eyes that needed vitrectomy in both groups were typically within 2.5 to 3 years of surgery. After that, none of them have needed a secondary procedure. When we look again below 1 year and above 1 year, you see that it's pretty comparable and there is no statistical difference. So it really doesn't matter in that sense. When we looked at glaucoma through these 84 months of follow-up, we found that the incidence of glaucoma was two eyes below the age of 1 year in vitrectomy group and only one eye above the age of 1 year, but again no statistical significance. So I think what I want to say is that I understand that this is a very skill-dependent procedure, and all credit goes to Professor Dr. Howard Gimbel for teaching us this procedure. And I think below the age of 6 months, it's particularly difficult to perform, having an equally sized anterior-posterior capsular axis and then being able to capture the lens. But above that, I think wherever you can, let's say between 1 to 6 years of age, if you can do a good anterior-posterior axis and capture the optic, you are able to avoid anterior vitrectomy and yet get equivalent outcomes. We are not saying superior or inferior, you can have the same outcomes. And I think the other important point is, despite all our best efforts, loss to follow-up in the long term is a reality we all need, and I think this can be considered as a paradigm shift for performing a technique or a paradigm for performing surgery below the age of 5 or 6 years. And I do strongly recommend that wherever possible, all of us should consider optic capture of IOL to avoid an additional procedure whose long-term side effects, vitrectomy, we don't know yet in these small eyes. Thank you.
Thank you, Dr. Vaishali. As we all know, pediatric cataract is a challenging situation. Every case makes you feel this way or that way. I would again request Dr. Mahipal to share his experience, as he himself is a star IOL surgeon.
Just one question, two questions, Dr. Vaishali. Was the IOL common in all?
Yes, the same 3-piece hydrophobic acrylic IOL. Same.
Okay, and would you find any difference between children younger, maybe less than 1 year? Yours was up to 4 years?
Yes, from 0 to 4 years.
So basically there is a lot of difference between you put a lens even at 1 month, 2 months?
No, typically now in our new strategy, we don't operate children below the age of 6 weeks.
Yeah, but your study said from 0
yes,
to 4,
so
that's what I'm asking, because normally conventionally we don't put a lens below 1 year, at least I don't.
Sir, we put in any eye which has anatomically meets the criteria. A corneal diameter more than 10 millimeter, axial length more than 17, we will implant at any age.
Unlikely to be.
True, sir.
But VAO occurs in 100% of pediatric case. And there is no proof record that anterior vitrectomy has some complication. And in your study also, there was no statistical significance. So
Right.
why do you say that we are not supposed to? Because that's a gold standard till today.
I agree that till today we have been performing vitrectomy to remove that additional scaffold for the lens epithelial cells. But when you perform an optic capture, because the anterior and posterior capsule leaflets are going to fuse, this will automatically confine the lens epithelial cells within the Sommering's ring and reduce, if not completely avoid, the migration into the center. And therefore, you may not need that additional procedure. And as for side effects of vitrectomy, yes, it's not proven, but Professor Stanley Chang from the US has shown in studies that vitrectomy changes the gradient of the oxygen free radicals and ascorbate levels, which may be a risk factor in causing glaucoma. Again, the other thing I also feel, which we are looking at in a longer data set, is the axial elongation in a vitrectomized versus a non-vitrectomized eye.
Yeah, that's important.
Thank you, Dr. Vaishali. We go
Thank
on
you,
to
sir.
the next speaker, Dr. Kothari.
Good afternoon, respected judges and my colleagues. I am excited to present to you a scale which you will be able to use for an objective assessment of magnitude of accommodation in kids, even very, very young kids. I have no financial interest so far. Accommodation in children is not frequently measured despite of a significant number of disorders which affect accommodation in children, such as Down syndrome, cerebral visual impairment, foveal hypoplasias, ectopia lentis, patients with unilateral or bilateral amblyopia, strabismic disorders with accommodative abnormalities, children with asthenopia, and nowadays with lots of use of low-dose atropine. At present, the dynamic aberrometry and open-field autorefractometry is not accessible commonly, and it is marred with underestimation of accommodation in children. Also, very young children cannot be put on these instruments. Hence, most pediatric eye surgeons would like to rely on dynamic retinoscopy. In our survey of pediatric eye surgeons of Mumbai in 2019, we found only 1 out of 18 pediatric eye surgeon was confident enough to be able to estimate accommodation in children when it was required. So we described this technique long back, wherein you use a direct ophthalmoscope and ask the child to look at the distance and read, and then look at the object at near, which is approaching the eye. And as the child would do that, you will find change in the reflex called Bruckner's reflex from superior crescent to an increasing inferior crescent. As documented in this video, child looking at the distance will have a superior crescent, and as soon as the child would start looking at near, you will find a crescent superiorly disappearing and an increasing, well-sustained crescent coming inferiorly. We coined a new term called dynamic distance direct ophthalmoscopy and published twice in Indian Journal of Ophthalmology in 2012 and 2019, and validated this technique with a very good intra-test and inter-test observer variability, as well as a very good correlation of almost 100% with the current gold standard, which was dynamic retinoscopy. If you neutralize the inferior crescent using a lens rec, as you see over here, you will be able to find the exact magnitude of accommodation. However, despite of describing this technique, even our colleagues in Mumbai were not able to start using it. So we decided, let's get rid of using the interjection of the lenses and create an accommodation scale and then validate it. The way scale was derived was like, ask a child to look at a distance who was emmetropic and then introduce the plus lenses to simulate the accommodative reflex. In a step of 0.5 diopter from 0 to 5, we were able to derive this kind of an accommodation scale with 11 pictures in it, which is similar to the scales available and were used in the past, like the pupillometer scale, the corneal ulcer diameter scale, the cup disc ratios that we decide are based on similar kind of concept. To detect 0.25 diopter difference in accommodation at a 90% power and at 5% statistical significance, our pediatric optometrist had to involve 15 eyes of 15 patients. And we included children between 5 and 16 years of age who were normal in health and visiting pediatric eye clinic for their routine refractive checkups. Both the techniques were performed at 4 different distances. As you see over here, the accommodation scale we felt was having less intra-test variability as seen by less standard deviation, as well as it did not induce the accommodation lead as was in the gold standard. So it was in fact better than the gold standard. Then we validated it among pediatric eye surgeons of Mumbai. We showed them 10 different scenarios and asked them to match what would be the accommodation. And this is exactly how clinically you will be using the scale. Like the lower panel, you match it up with the upper, and where the child is looking will decide whether there is a lead or lag of accommodation or normal accommodation. The only limitation of this technique, I think, is still the lens interjection was used, and hence in the previous picture you can see an extra reflex. Also, I still feel it's not going to be picked up by pediatric eye surgeons across. People would like more of technology and of course having something which is better documented. For now, I think accommodation scale is here to stay. It is a very easy and rapid method to assess accommodation in children objectively. Thank you very much.
You have shown high statistical significance. So what was your significance test that was done? What test was done statistically to show the significance?
So madam, we used 2 tests. One is the Pearson's R, it's a correlation coefficient. With the intra-test variability for that we used the t-test, and the paired t-test was used.
Used a paired
because the same child was assessed on 2 in sequence.
Thank you.
Thank you, Dr. Kothari. We go on to the next speaker, Dr. Shetty from refractive surgery segment.
Thank you so much, sir. Good afternoon, everyone. I would like to thank AIOC for giving me this opportunity. These are my financial disclosures. I'm sure each one of us had cases where we have done a perfect workup, we have put in our 100% effort in terms of the calculation and selected the lens. Even in the OR or in the OT, you have done a perfect seamless surgery. And next day you see the patient is also very happy. And the vision, when you see it's 6/6 vision. But when you look at the slit lamp or the OCT, you end up with a picture like this, either it's very high vault or very low vault. Now, why does this happen sometimes? So this is because we rely or we only see the horizontal wide to wide, and we do a lot of assumptions which are not true. For instance, the shape of the limbus is always elliptical, or the horizontal wide to wide is always maximum, and the vertical wide to wide is always minimum. So this is why we, now and then these surprises come up. So the research question is, can we actually develop a formula which can predict the vault even better? So first what we did is we made a unique software which takes the pentacam densitometry scan. The values in the 256 grayscale is plotted, and the rate of change of the densitometry is seen, so that you can exactly mark the wide to wide, and this is done 360 degrees, and all these values are plotted. Now, incidentally, we found something very interesting when we looked at this data. The horizontal wide to wide, the shortest horizontal wide to wide, correlated beautifully with the steepest axis on the cornea. Now, which actually we even published this particular data. But anyway, let's keep aside the incidental finding. By using this particular 3D software, we took all the values of maximum wide to wide, minimum wide to wide, max angle, minimum angle, horizontal wide to wide, vertical wide to wide, and plus all the other data of pentacam, refraction, ICL parameters, post-operative actual calculation of the wall size and the UBM predicted wall size, and put all of this into AI, and we found something very interesting. So if you look at the post-operative the new estimated post-operative vault, the coefficient of determination value, or the R square, is 0.74, and the interclass correlation coefficient was 0.92, which is very, very good. So, and let's compare with all the formulas right now in the market. If you look at the right side, the R square value, which can vary from 0.06 to 0.3, 0.4. The best formula right now is the Lasso formula, which is about 0.68, and our formula is able to perform even better than that. To summarize, basically with this novel 3D corneal diameter software and AI-driven ICL sizing, we are able to predict the vault even better, and we were able to have a coefficient of determination of 0.74 and interclass correlation coefficient. Basically, it indicates the reliability of the measurement of 0.92. Basically, the closer to one value it is, the better it is. Thank you so much for your time.
Thank you, Dr. Shetty. To you, sir, for your comments.
Yeah, Dr. Shetty, have you used the findings that you got from this study and correlated to clinically? Did you get better results with your ICLs after?
So yes, definitely. So we have done both prospective and retrospective analysis. So what we have done is we have taken only clean data and fed it to the AI so that we have more reliable results. And plus what we have done is we have tested retrospectively also other cases which, even though it's not a clean data, we have analyzed it and then seen and compared the post-operative vault and plus what the formula is detecting. It's correlating very nicely. And also all our patients, we are doing the same, using the same formula. So why this accuracy has significantly improved as compared to our current formulas is because of the new software, the data which we are adding to the AI, the 3D mapping of the corneal diameter or the wide to wide. That data is actually very useful for it to predict even more better.
So, Naren, just a thought, you're looking at just the pentacam, right?
Pentacam and STS also, UBM STS values.
Oh, no.
The vault prediction.
So you are
adding both values, sir.
Okay, and what about, say, doing an IOL master or the manual thing and then adding on, or maybe doing an OCT? And
Yeah, that is a possibility, sir, definitely. So, but right now for this formula, we just took
because
two.
The confusion, yeah, I understand.
Yes,
the confusion is there are 5 ways to do a
correct, sir.
wide
Skin and
wide.
cat,
So
yeah.
basically, maybe the AI can throw up something good in those things.
Absolutely, sir. Absolutely. Thank you, sir. Thank you so much.
Dr. Nayantara Chauhan. If she is absent, we go to the next speaker.
That's Dr. Chinmay, sir.
Sorry?
Dr. Chinmay. Marushka already did her presentation as a second speaker. 19 is done.
Now we go to
have
number
Dr.
20,
Chinmay.
Professor Dr. Chinmay.
Nayantara Chauhan, once again. No. Okay.
A very good afternoon to all of you. I'm talking on taming the untamed, globe repositioning to the rescue. no financial interest. The aim is to describe the clinical features and management of globe luxation. It's a retrospective interventional case series from RIO Bangalore over 6 years. So we see all sorts of trauma, mostly bone injuries or soft tissue injuries. But there is this extreme type of trauma where the globe luxates out of its 30 ml of the volume of the orbit and comes out completely. It's a combination of RBH, optic nerve avulsion, partial or complete, and severe spasm of the orbicularis, which prevents the eyeball to go back inside. The option is to enucleate the eye and give an implant, but can we do something? Can we salvage the eye by globe repositioning? So the age group is 1.5 to 58 years and 6 eyes in 5 cases. The difficulty is the associated CNS injuries, the systemic issues, the difficult GA and multiple surgeries that may be required in these cases. So this is the first patient with bilateral globe luxation following a trivial trauma. She just fell from the bed and this is how she is. And the saving grace was a 3 mm and reactive pupil despite the extreme proptosis exposure keratopathy. So we suspected bleeding disorder and she was found factor 13 deficiency. After transfusing cryoprecipitate and doing a lateral craniotomy, the chemosis is being reduced through a conjunctival incision. So here there was a lot of issue with GA as the patient could have life-threatening bleeding through the in the throat. And I'm using a periostal elevator to reduce the chemosis. And after that, the globe is being reposited and a temporary tarsography is being done on the lateral aspect. Care to be taken not to damage the cornea. We shouldn't put the suture in the center of the eye. So this is the lateral part and the other medial suture as well. And you can see that the same procedure and this is the patient. The end of surgery, the sutures gaped and I had to redo the procedure. 1 month later, this is how she was, and 3 months later, this is how she was. So with this, from here to here, she's come a long way with a good distant vision and also a good near vision. She achieved 618 despite the corneal problem. So this is a case 2 with RTA in an elderly male, and a similar procedure was done. Here again, lateral canthotomy was done. This procedure is done under local anesthesia as he had other fractures and we didn't get clearance for GA. So similarly, the globe, here this patient's vision was PL negative. Although the vision can't be salvaged, we can at least save the patient's eye. So a similar procedure, lateral tarsorrhaphy, medial and lateral temporary sutures were done for this case. And this is the patient's appear immediately after surgery, and this is at the end of 3 months. And you can see, surprisingly, the patient, in spite of having extraocular muscle dehiscence, did not develop anti-segment ischemia. I'm also intrigued with how it is possible. And the third case, 5-year-old bulgur injury, bad trauma, and here again he was PL negative. And this is the imaging, and this is how the patient is. Again, because of this chemosis, the sutures keep on giving away, and we repeatedly go on doing the tarsorrhaphies. And this is case 4, hydrocephalus and Crouzon syndrome, difficult GA. So this is the same procedure done for this child, and this is how she is. Many of these children require a later skin graft, which I will be showing in this case 5 Crouzons again, and partial. This is a partial subluxation, and here I have used skin graft on all 4 lids, and this is how the patient is. Notice that the squint with amblyopia treatment and all, the squint is also getting aligned. So the discussion, it's partial or complete, and till now there are 109 cases that are reported and could be post-trauma, spontaneous, as in cases of these syndromes with a shallow orbit, and sometimes with bleeding disorders, voluntary also described. The reason any object entering the medial orbit could just get the orbit out, or the optic nerve transection. The conclusion is you always have to save the eyeball, if not the vision, at least the globe. And later these patients may require squint surgery, skin grafting and all for better cosmesis. Thank you very much.
Thank you, ma'am.
Very nice presentation. Only one thing, like you have shown 4 cases.
5 patients, 6
So
eyes.
3 of them are basically trauma.
Yes,
So you
ma'am.
have done only cantotomy or cantolysis also?
Cantholysis also,
Also,
ma'am, because only canthotomy will not reduce the orbital
Exactly.
volume. So
And for the
both.
cruisons that you have shown, the pathology is in the bone, in the
Yes,
socket.
it is in the soft tissue.
Only a soft tissue, I mean, surgery will not help in the long
Yes,
run.
ma'am.
You
These
have to do
patients
a
are
socket
planned
expansion.
for bone expansion, which cutting out the orbital wall and a bone implant
Exactly.
is planned for them.
Distraction,
Yes, just for the,
osteogenesis.
because they were not clear for a longer surgery under GA, we had to do this temporary procedure. The two kids are planned for that under the neurosurgery.
Very
guidance.
nice.
Thank you
Thank
so
you.
much.
I hope you know that auto-luxation of the globe is also possible. Anyway, we go to the next speaker, Dr. Maria Bano from trauma segment.
A very good evening. Today I'll be presenting a tale of two trauma, which means a visual outcomes in closed globe injuries with and without head trauma. Ocular trauma has a wide variety of presentations, ranging from a contusion to a globe rupture, and a patient presents with a vision of 6/6 to patients with no perception of light. Our main aim of the study was to analyze the influence of head trauma in the visual outcomes of patients with closed globe injuries. It is a cross-sectional study of study duration 3 months. We took 300 patients and they were broadly classified as group 1 who had both closed globe injury and head injury, whereas group 2 who presented only with a closed globe injury. We included the age group of 18 to 65 years. Patients with severe head trauma with GCS less than 9 and an open globe injury was excluded from our study. Visual acuity during the first presentation of the trauma and at the end of 2 months was recorded. We also took factors like a concomitant head injury, a lid involvement, a bony orbit involvement, and their influences on visual outcomes in both the groups was analyzed. Results: in our study, the predominant age distribution was of a younger age group, less than 30 years in both the groups, and it was a preponderant male gender was involved in our study. The causes of closed globe injuries in both the groups was road traffic accidents, and the ocular manifestations in group 1 who had both ocular trauma and a head trauma was papilledema, whereas in group 2 it was subconjunctival hemorrhage. We also took into account the impact of GCS on visual outcomes, where we saw that in patients with moderate head trauma, that is GCS of 9 to 12, 38.9% of the patients improved in visual acuity, whereas in mild head trauma, it was more, 56% of the patients showed an improvement in visual acuity. Visual outcomes in patients with papilledema, in group 1, it was 27.3% of the patients, whereas in group 2, all 100% of the patients showed an improvement. Here, we also account the papilledema in group 2 patients who presented only with the ocular trauma is because of the bilaterality of the ocular trauma, and it also disappeared by 2 months. The exact origin of this disc edema may be due to a head injury, which is not evidenced by radiological investigations. This graph shows the incidence of RAPD, which was very much higher in group 1, that is, patients who had both a concomitant head and ocular trauma. We also analyzed whether this RAPD had a visual outcomes in the patients, where we saw that in group 2, 21 patients had RAPD and all of them had an intraorbital or canalicular injury. Of this, 6 people did not improve and 15 showed improvement. For some patients, orbital nerve decompression was also done. Visual acuity improvement in patients with bony orbit involvement. In group 1, blowout fracture was the most common, and group 2, medial wall was most common. And this graph also shows the respective improvement of the patients. As mentioned earlier, we also took into account whether the lid involvement had an influence on visual outcomes. In group 1, 56%, and in group 2, 75% of the patients showed an improvement in visual acuity. Discussion: presence of head trauma in patients with papilledema had a poor prognostic factor, and the results are statistically significant. The presence of RAPD in patients with head injury had poor visual outcomes, and the results were statistically significant. And the review of literature also showed that RAPD grades were associated with poor visual outcomes. In our study, we found that bony orbit involvement affected the visual outcomes in both the groups, even though the results were statistically insignificant. And we also concluded that visual acuity at the end of 2 months in patients with lid injury improved, and the results were statistically significant. So these are our conclusions from our study, that when there is a head trauma which happens along with a concomitant ocular trauma, It adds to an important prognostic significance. Presence of papilledema in the presence of head injury is a grave prognostic factor when we take into account the visual outcomes. RAPD, if present in association with head trauma, is a more ominous sign. Bony orbit involvement, if present, along with a concomitant head injury, decreases the visual outcomes, and lid injuries did not decrease the visual outcomes in our study, irrespective of what group the patient belonged to. So we conclude that papilledema, RAPD, and bony orbit involvement are the factors which predicts the visual outcomes, and these are the three factors which we took in our study, who had a concomitant head and ocular trauma. These are my references. Thank you.
A very nice study. I have a question. You have mentioned an RAPD is a poor prognostic factor. So did you grade the RAPD? Have you used a neutral density filter?
We just, at the initial time of presentation, we used it and we just graded it, ma'am. Clinically only we saw the patient, ma'am. We graded it accordingly.
Because it's very difficult to know what is clinically, like how will this affect the prognosis, right? If you don't grade it with a neutral density filter. That is number one. Number two, how did you manage these patients? For the RAPD?
Traumatic. Most of the cases were due to a traumatic optic neuropathy, and in some cases optic nerve decompression was done, as we mentioned, whereas the other patients were managed by using steroids in cases where it could be managed conservatively.
Okay.
Thank you, ma'am. Last but not the least, presentation by Dr. Harsha.
Good afternoon, everyone. I'll be talking on the sarcoidosis tuberculosis conundrum and the role of serum ACE, MAN2, and lymphocyte count. Ocular TB and sarcoidosis are two diseases with overlapping clinical features, and hence differentiating one from the other is a challenging task. They are even postulated as opposing presentations of the same disease spectrum. Even though ACE, MAN2, and lymphocyte are commonly used in the diagnosis of sarcoid and TB, the sensitivity and specificity vary in different study populations. Studies depicting their utility in combination are scarce and are quite relevant in TB endemic countries like India. Our study attempts to address this lacunae. The purpose of the study was to evaluate diagnostic utility of serum ACE, MAN2, and lymphocyte both in isolation and combination in the diagnosis of ocular TB and sarcoidosis. The outcomes studied were sensitivity, specificity, positive and negative predictive values. This is a prospective observational study done for 2 years in Aravind Hospital, Pondicherry, in 95 patients with acute uveitis of age more than 18 years. We excluded patients with history of trauma, immunosuppression, patients on ACE inhibitors, steroids, and immunosuppressants. The diagnostic criteria used were the revised IWIS criteria for sarcoidosis and the Gupta et al. Criteria for ocular TB. ACE was estimated using a substrate FAPPG. We analyzed 118 eyes of 95 patients. Ocular TB was seen in 12% of the study population, and 20% of the study population had presumed sarcoidosis. ACE was elevated in 89% of the sarcoid group, but was elevated only in 33% of ocular TB group. The mean value was 76 in sarcoid and was statistically significant when compared to TB. MAN2 was positive in 58% of the ocular TB group and only in 15% of the sarcoid group. The mean value was 12.67, which was also statistically significant. Lymphopenia was seen only in the ocular sarcoid group, and this was seen in 10%, and none of the other groups had samples with lymphopenia. Elevated ACE had a very good sensitivity and negative predictive value in detecting ocular sarcoidosis. Also, negative MAN2 had a good sensitivity and negative predictive value, but their specificity and positive predictive value was less. Since lymphopenia was seen only in the sarcoid sample, the specificity and PPV became almost nearly 100%, and also when all the three parameters were combined, the specificity and positive predictive value became nearly 100%. Both elevated and non-elevated ACE had a good negative predictive value in detecting TB, and there was an overlap, and positive MAN2 had a very good negative predictive value in detecting TB. The area under ROC curve for sarcoidosis was maximum for elevated ACE, and when compared to lymphopenia and negative MAN2, this was statistically significant. In ocular TB, the AUROC for positive MAN2 was 0.835 and significant. This is a prospective study done by a single trained observer in a single tertiary eye care center. To the best of our knowledge, no study conducted so far has tested the combined utility of elevated serum ACE, negative MAN2, and lymphopenia in the diagnosis of ocular sarcoidosis. Our study also analyzed the utility of serum ACE in ocular TB. The limitations are, this is an observational study, so there was no randomization, and study period included peak phases of COVID pandemic, so viremia could have affected the lymphocyte values. There were no biopsy-proven cases. Subjects included were either presumed or probable sarcoidosis and probable or possible TB. What this study adds to, study by Elango et al. From South India says elevated serum ACE was an independent risk factor rather than lymphopenia alone or in combination, whereas study by Philippine Court et al. Says combination of ACE and lymphopenia demonstrated a better diagnostic performance compared to these tests alone. According to our study, combination of elevated ACE, negative MAN2 and lymphopenia had a better ability to diagnose sarcoidosis than these tests in isolation. As NPV is very high, in subjects with normal ACE, further screening for sarcoid may be required only if clinical suspicion is high. Even though ACE was elevated in some patients with ocular TB, it may not serve as a useful tool in diagnosis of ocular TB. As NPV is very high, in case of negative MAN2, further screening investigations for TB may be necessary only if there is a strong clinical suspicion. Serum ACE level is a better test for discriminating ocular sarcoid when compared to negative MAN2 and lymphopenia. Also, MAN2 test is a better test for discriminating ocular TB from other diagnoses. These are my references. Thank you.
Your comments, sir. Your comments.
We have done a study that Elango et al. Is our study. We found that the combination of the serum ACE and lymphopenia is a good indicator for sarcoidosis than tuberculosis. I just want to know, this is an elegant study, I just want to know that how do you explain that sarcoidosis is also, causes energy? How do you explain the overwhelming response of tuberculosis patients having, sarcoidosis patient having positive MAN2 test? Is it that, like, you know, being Indian, we have got so much of exposure to the TB, it overwhelms, that's what I explained, overwhelms the immune system to have that positive, small segment of tuberculosis patients, or small segment of sarcoidosis patients having MAN2 positivity. Classically, it is negative, but it is a positive in some percentage of cases, your finding and our findings also.
Sir, recent meta-analysis studies postulate Mycobacterium tuberculosis to be an infectious agent, which is also responsible for sarcoid. So patients having sarcoid can have a concomitant latent TB infection also. So this might be the reason for them having a positive MAN2.
So actually, both of them produce granuloma.
Yes.
So that produces a kind of reaction.
Yes.
पता नहीं मैंने भेजा था तो बच्चे को आया नहीं.
Yes, sir.
चलेंगे एक बार आगे आगे.
It's sarcoidosis, yes.
और तो चलिए अब चलते हैं उधर. कुछ तो मिलेगा.
Thank you, sir.
With this, we come to the end of this wonderful session. While thanking my colleagues on the dais, I congratulate all the participants. For us, you are all the winners. Let us hope who wins the race ultimately. Wish you all the best.
Thank you very much, sir. On behalf of the scientific committee, I take this opportunity to thank our honorable expert judges, Dr. Mahipal Sachdev, Dr. Kasturi, Dr. Lalit Kumar, Dr. Maskati, and Dr. Meena, and Dr. Jyotirmay Biswas for your time. And we had an array of presenters, showcasing the progress and advance in science and ophthalmology in India. And we do had an array of speakers, including postgraduate students who came in to present their paper at Colonel Rangachari. Congratulations. Thank you very much. Thanks a lot.